Writing Committee member of Under 5 Users module of IAP, the Writing Committee member of Writing Antimicrobials responsibly of module of IAP, National Trainer for IAP and TB, PP, TB module, NRC CUF module, etc. Sir has done many presentations as faculty at IAP and other platforms, and past president of IAP, Thane chapter. Welcome, Dr. Vaidya. Dr. Mukesh Sanklecha is consulting pediatrician, Bombay Hospital Institute of Medical Science, Mumbai, Sefi Hospital, Mumbai, and has been in practice for past 30 years. So the passions of Dr. Mukesh include pediatric allergies, pediatric asthma, pediatric infectious disease, and teaching. More than 45 publications in Index Indian and international journals. Dr. Mukesh has been a faculty at large number of national and international conferences. Welcome, Dr. Mukesh. Dr. Anil M.U. Sir is MBBS MD in Pediatrics with Fellowship in Pediatric Critical Care, DA, Diploma in Allergy and Asthma. Sir is Lead Consultant Pediatrics and Pediatric Critical Care, Sparsh Hospital, Bengaluru. With this brief introduction, I hand over the session to Dr. Prakash Vaidya. Over to you, sir.
Thank you, Dr. Prashant, for that introduction. And we will now go into our topic of today's discussion. The role of Oseltamivir in flu management. So I propose to start with a very short introduction where we will have some foundation facts of the topic, including something about the virus, something about the disease, and something about the drug. After that brief introduction, we are going to get the panelists to give us their views, and we will have a very lively discussion on the role of Oseltamivir in flu management, trying to cover as many dimensions as possible of this topic. Now let's look at the foundation facts. The virus of influenza, the clinical picture, and the antiviral. Now we know that influenza is widespread, and in the last monsoon, this current, which is still on in most parts of the country, we have had huge epidemics of influenza. And we believe these figures because there are almost 1 billion annual cases in the world, 3 to 5 million severe cases, and the mortality is thought to be almost 300 to 600,000 a year. So this is the kind of problem that flu has. And the virus, as we all know, is a single-stranded RNA orthomyxoviridae family of viruses. And there are 4 types of flu viruses, A, B, C, and D, of which types A and B cause annual epidemics. Type A also is known to cause severe pandemics. But type C is less common, hardly any symptoms, and type D only in cattle. So our focus of interest is the virus type A and type B. Now type A is further classified into 2 subtypes, and that depends on the proteins on the surface of the virus. So there are 2 important proteins on the surface of the virus, the HA, heme agglutinin, and the NA, that is neuraminidase. So depending on the type of HA and NA, the virus is subclassified. Now, these 2 proteins have a big role in that HA allows the virus to bind to the cell, and NA permits the virion particles to exit the cell. So both these points of entry and exit can be attacked by antiviral drugs as well as by antibodies which can be generated against these specific moieties. So these proteins are targets for both antiviral drugs and antigens to which antibodies can be raised. So as of now, influenza A virus circulating in humans are mostly A, H1N1 and H3N2. But as I'll talk a little later, there are a few other viruses also. As far as the other important virus B is concerned, it is not classified into subtypes, but into 2 lineages, the B Yamagata and the B Victoria. So this is about the virus which is causing so much widespread devastation. The symptoms. Symptoms are like any other viral illness, flu, fever, headache, myalgia, cough, rhinitis, ocular symptoms. So like a typical virus, the flu virus also causes multisystemic symptoms. It causes headache, it causes nasopharyngeal symptoms like runny nose, systemic onset like fever, respiratory symptoms like cough, vomiting, sometimes even diarrhea, joint pains, and muscular tiredness. And the duration is between 2 to 7 days, averagely. So it is actually like a common cold, but much worse. So they say severity of the flu virus is like a severe cold, but severity can be subjective and inconsistent. It varies from person to person. And now let us take one look at the foundation facts on antiviral drugs. So initial antiviral drugs that were available were adamantine drugs, amantadine and rimantadine. This is history now because the resistance to these drugs is so widespread that they are no longer used. So we'll not talk about them. Then the all-important drugs, that is the neuraminidase inhibitors. These neuraminidase inhibitors prevent the release of viral particles, virions, from the host cell. So in a way, they stop the virus in their tracks, they stop it from replicating, and the replicated particles are not allowed to enter the circulation. So the viral progress is aborted. So neuraminidase inhibitors are active against both A as well as B viruses. Apart from that, there is favipiravir, RNAP inhibitor, and baloxavir. The last one is not available in our country. So, which are the available antivirals in our country? The neuraminidase inhibitors, and of that, only and only oral oseltamivir is available. Intravenous peramivir, inhaled zanamivir, and lanimivir, these are not available in India as yet. And baloxavir, which is not a neuraminidase inhibitor but something else, that is another drug that is under trial in India but not yet available. So for us in our armamentarium, there is only oseltamivir. But oseltamivir has stood the test of time. It was first approved for medical use in 1999 and the first neuraminidase inhibitor available by mouth. Thereafter, it is a potent and a selective inhibitor of the neuraminidase enzyme. The oseltamivir is a prodrug which is converted to oseltamivir carboxylate in the liver, and it prevents the spread of influenza infection. How does it do it? By not allowing the viral particles to enter into the circulation and even halting them in their replication. So this is a little bit about the foundation facts, for which I thought I would just take an overview. And now I will now invite my panelists to give me their expert opinions as I present some cases to them. So let us look at case one. This is a 2-year-old boy with high-grade fever, cough, cold. Initially, the child was interfebrile active. But now on day 3, he has become lethargic. His intake is poor, so there is some dehydration. So clinically, it looks like a so-called ILI, an influenza-like illness. And now we have admitted the child. So Dr. Mukesh, what is the differential diagnosis of this so-called ILI?
So firstly, this child is pretty unwell and requires hospitalization. Now, this could be a viral infection, could be a bacterial infection. Can you go back to the first slide, Prakash? So here you have fever, cough, cold, all of which tells us this is probably a viral infection. And a 2-year-old child, we are looking at viruses like rhino, RSV, adenovirus, of course, influenza, parainfluenza, human metapneumovirus, and our order of viruses change depending on which outbreak is happening. Like about 2 years ago, we had a huge adenovirus outbreak. So where adenovirus shifted on top. But currently, I think we are seeing a epidemic of influenza. So that becomes our number 1 virus in terms of prevalence of viruses.
Possibly even RSV is a culprit, Mukesh. Don't you think RSV also is similar?
Absolutely.
Yeah.
Unlike in the West, where they speak about autumn and winter as the peak season, for us it's more the monsoon and the pre-Diwali period where RSV is higher. I agree with you, Prakash.
Yeah. So, Dr. Anil, is
Yes,
there
sir.
any other non-flu type of, non-viral RTI, which is not like influenza-like symptoms, like respiratory symptoms? Can it be confused with flu? What do you think?
Usually, no, sir. You should be able to pick it up. If you take out the detailed history, we should be able to do it. Because enteroviruses sometimes happens in small babies, comes with a
How
localized
about
symptom.
dengue? Sometimes dengue can also confuse the clinician in the initial stages, and then it may look like flu at that point of time. Do you agree that in the initial phases it may look
Dengue,
like
day 1 and day 2, they come with a very high onset fever, breakbone kind of a fever, severe headache, body pain, and all that. And few of them may have a conjunctival injection also. This is one point which may kind of confuse us with the flu. But again, respiratory symptoms may be conspicuously absent. But as we know, sometimes
dengue also has got a dry cough. So I have sometimes had a confusion between dengue and flu, but that's only in the initial period. Do you agree, Dr. Mukesh?
Absolutely. By and large, we would diagnose dengue clinically based on the epidemiology, the occurrence in the community, and actually the absence of cough and cold. But yes, Prakash, that can happen.
Sometimes dengue can have a little
Absolutely.
catarrh.
Yes,
Now, in a child, Dr. Anil, how do you distinguish between severe flu and non-severe flu as per the WHO guidelines?
Non-severe flu are the ones which will typically require hospitalization. The moderately sick will kind of go into the ward or a HDU. The severely sick will go into the ICU. We may see some progressive symptoms in respiratory tract. They may develop to a full-blown pneumonia, ARDS kind of a picture. And if it's a progressive illness, they may develop a multi-organ involvement. Like they can go on to develop a liver and a kidney involvement and a multi-organ involvement. Those are the severe flu cases.
And more importantly, the CNS part of it.
Yes, sir. Yes. So we are seeing quite a bit of CNS complications, children presenting with febrile seizures and very high grade fevers leading on to a little bit of delirium and febrile delirium, and sometimes very rarely encephalopathy also.
So WHO says severe flu is by serious illnesses, as Dr. Anil said, sepsis, septic shock, severe pneumonia, ARDS, multi-organ failure, and any of this can occur. And many of these patients require ICU, mechanical ventilation, vasopressors, and anything. So flu cannot be underestimated. It is one of those severe viruses, and it can result in mortality also. So in this patient, now to come back to our patient, Dr. Mukesh, what would be your management of this child?
So you've hospitalized the child, his oral intake is poor, so he will require obviously parenteral fluids. And you would be monitoring his saturation, seeing if he has hypoxia, he may need oxygen, and most of it is supportive. Now, the only question is whether you would start any specific therapy for this child. So I think that's a question that is difficult to answer, but by and large, you have a flu epidemic in the community. You have hospitalized this child. He is either in the hospital room or in the ICU. But either ways, once you hospitalize the child, you would empirically start Oseltamivir pending investigations.
So I think here we are all on the same page that in this child, in the flu season, 100% we will start Oseltamivir. And then, of course, while starting, if possible, we will send a nasopharyngeal swab for influenza, right? Would you all agree with this?
Absolutely.
Right, sir. If someone is sick enough to get admitted, yes, we would send it across.
So here you will do the supportive management, as Dr. Mukesh said. We will start specifically Oseltamivir, and we will simultaneously try to confirm our diagnosis by sending a nasopharyngeal swab. Now let me look at a case which is similar to this but a little different, and I wanted your perspectives on this. Now this is 18-month-old male child, Shlok. He has had a past history of a typical febrile seizure. So he comes to you on day 2 of fever, and now this time he's brought to your clinic with history of one more febrile seizure. But by the time he has come, he's active and playful. So you thought he is quite active, playful. Why admit him? He was sent home on symptomatic treatment. His intermittent high-grade fever continues, but he's still active interfebrile. And 12 hours later, he is again brought to your clinic with another short-lasting episode. This time, you don't take a chance and you admit the child. Now, this child, after the second episode in this particular illness, is now again playful, active. He's not a very sick child. So now I want to know from both of you, in this situation, will you give Oseltamivir or not?
Right. So this is a child who is in the high risk category. Anyone who is less than 2 years would classify as a high risk category when this epidemic of flu is going on.
Right.
Even though we have admitted this child for probably a complication of the fever, like a febrile seizure, because there was a recurrence, we ended up admitting. And the child is still active, playful, but maybe spiking high grade fevers. And since we don't have any other diagnosis and the epidemic of flu is going on, I would like to start this child on Oseltamivir, wait for the labs to come in, the CBC, CRP, and other things, or to see if he develops any other localizing symptoms, probably some Oseltamivir, some clobazam, and probably we'll wait and watch as to how he progresses.
Yeah. So, Mukesh, do you think this was a CNS flu, considering he had so many seizures, if at all it was flu?
Yeah, so Anil, so I think I agree with Anil that since he is below 2 years and at risk for severe flu, he would give Oseltamivir. But the primary indication for admission was the febrile convulsion and parenteral concern. So since the child is so well between episodes, this is unlikely to be a influenza encephalopathy. More likely it's a febrile seizure, and our indication for admission is primarily neurological for observation and in anticipation. But I think the two are separate. You have hospitalized for the seizure, But because it's a flu epidemic, he's 18 months at risk for influenza, for severe influenza. We have started Oseltamivir.
So
Both
I
are
think
safe.
we are all on the same page that here we will still give oseltamivir no matter what the other, because we don't want to take a chance on a child who is getting multiple seizures and we want the fever to come down soon. Okay. This was the report of the child. His now I'm sure it's not very clearly readable, but let me read it out to you. It showed influenza A, H1N1 not detected, H3N2 not detected. Only A was there. So this was some other type of uh, uh, flu virus. We could not classify it, but this was flu in the end, and this child did well. So now, Mukesh, I'll give a little tweak on this case. This is a
Prakash, one thing, by epidemiology wise, does it help us to classify the kind of subtype of the influenza virus?
Yeah, that's a good question. I don't think it does. But then, sometimes there is a very outbreak of some really a different kind of virus. And if we were to classify it, we would be warned in time, because this is a different, it could be a zoonotic virus, which is now just showing up. So
Correct.
yes, I think it may not help the individual child, but
Right.
it will definitely help the community.
So
To
our treatment would remain the same.
The
But yes,
treatment
in
remains
terms
the
of
same. And luckily, oseltamivir is still very useful in all
yes.
the H1 and H and N variations. So I think we should be, but yes, classification would help the community. So now I'm tweaking this question a little, that this same Shlok, he came to you and he was active and he did not have a second seizure. You did not admit him. His intake was normal, but not normal, but okay. He's passing good amount of urine. So in this OPD patient who has had convulsions twice, but this episode one, here, do you think that you will give oseltamivir here? And I want a quick one-liner from both of you. So Dr. Mukesh first.
So if you have not hospitalized him, he is 18 months. There's an epidemic going on. That way, every baby who's below 2 with cough and cold which comes to the OPD, I would give oseltamivir. So the answer is no. I would not give this child oseltamivir unless there is an indication for hospitalization.
Yes. What about Dr. Anil?
If he's active and playful, even I would withhold it, sir. I wouldn't give.
Right. So the take-home message is that go by a case-by-case basis and look at the individual child. So now, however, which are the children to whom you will give oseltamivir upfront? So I would like both the panelists to take up. Dr. Anil, in your
Yes.
practice, who are the patients whom you will straight away give oseltamivir when you suspect flu? You will not wait and you will not even do the test immediately. Which are
Yes,
those
sir.
patients?
These are a category of high-risk children. They may fall into the high risk because of their age. So
Mhm.
usually we classify anybody who is less than 2-year-old as high-risk group. And even if it's an adult more than 65, or the Western literature may say 85 years. So anybody at the extremes of age would fall into the high risk based on their characteristic of age. And also if there is any other kind of a compromise in their immune system. They may be immune suppressed because of multiple reasons. They may have a chronic lung disease. They may be asthmatics. They may be cystic fibrosis, other chronic lung diseases, BPD, who's born preterm and having a BPD. Definitely, we would consider them as a high risk disease.
Any chronic lung
That
condition like asthma, cystic fibrosis, BPD?
Yes, any chronic CVS
Yeah.
kind of a disease or a liver disease, primary immunodeficiencies, anything which requires long-term care would classify as a chronic disease. And these are all high-risk conditions where we would start oseltamivir upfront.
So there is a condition like this is the chart from up to date, which says even a cerebral palsy high risk, neuromuscular disorders like muscular dystrophy is high risk, and interestingly, extreme obesity.
Obesity,
So
yes.
if the BMI is more than 95th percentile in an obese child, there your index of starting oseltamivir becomes very low. You have to start because this is an at-risk child, and of course, a child who is on immunosuppression, like a child on steroids or a child on an anti-malignancy drugs. 100% this child we will start upfront. Now, Mukesh, is there
Prakash,
any?
one quick comment.
Uh,
If you look at guidelines for asthma, they say
uh,
maybe a well-controlled asthma does not qualify for the flu shot.
I
So I
agree
was
with you.
wondering whether you would break down this asthma into poorly controlled, uncontrolled versus controlled.
So the literature doesn't say that. No, this
I
is the
know.
from up to date. But I think you have to take if the child is perfectly controlled and perfectly all right, and he is
Correct.
on ICS. But ICS is not taken as an immunosuppressant. So
Absolutely.
so I think that you can take a decision on a case by case basis. This is just to illustrate that which children you are more likely to start oseltamivir upfront.
Fair
Children
enough.
suffering from a concurrent active disease and interestingly enough, in today's times, obesity. So
Yes.
apart from this, what I want to know that is there any other indication other than this where you would start a child upfront on oseltamivir therapy? And I would like Mukesh to take up this question.
Yes, that's a very interesting question. So you have a low risk patient, but you have a high risk contact in the family. So you have
Absolutely.
somebody in the family who's immunocompromised, a mother who's pregnant, and old person who's above 65. So all the high risk categories also become high risk in terms of contact. So a child in such a family would qualify as a candidate for oseltamivir, even though the primary indication is not for the child, it is for the family itself.
That's a very interesting. That's a very interesting point which Dr. Mukesh has brought out. That sometimes you started because the child has a high risk contact. There may be a malignancy patient at home on anti-malignancy drugs. There may be an elderly person who is suffering from diabetes. There may be a very tiny baby at home, newborn. All these are vulnerable children. So to protect those vulnerable children, you will start oseltamivir in your patient, even though on merits he may not have needed that. Is that right?
Absolutely.
Yes.
Spot on,
Yeah.
Prakash.
Yeah, Dr. Anil, would you agree?
Yes, sir. Yes, sir.
Yeah. So treatment may reduce the amount or duration of viral shedding, lessening the risk of transmission to the high risk contact. Now, questions to both of you. So, Mukesh, Dr. Anil, have you used oseltamivir in any case which has a non-respiratory presentation initially? Do you think that
Yes.
there is a role?
Yes, sir. Yes, sir. Definitely there is a role because I practice a bit of ICU also. So
Mhm.
anybody who is sick enough to get admitted in the ICU, they're extremely sick. They're encephalopathic at admission. They're in a status epilepticus. There
Right,
is a febrile encephalopathy going on. These children, we need to act very fast. So we
right.
make a syndromic diagnosis. So in such a situation, we won't wait. We will go ahead and start them on the appropriate antibiotic.
That's a very, we'll
And
be taking a case of that. And so we'll come to the other dimension. That's a
yeah,
very interesting assertion by Dr. Anil that he would start oseltamivir even if there are no flu symptoms in a high risk patient in the flu season, right?
right, sir. Yes.
Yeah. Now, Dr. Mukesh, is there any other, like if a patient came with high fever and diarrhea and it crosses your mind, okay, can this be flu? Do you think that there is any role of oseltamivir in such a patient?
No, I think diarrhea, isolated diarrhea, in the absence of a cough, cold, a respiratory manifestation with only fever is unlikely with influenza. Though some viruses can cause multiple mucosal involvement, but diarrhea is a atypical manifestation in influenza. So, if a child came with fever and loose motions,
So
uh,
not the outset,
flu
but
would not.
if he develops respiratory symptoms the next day, probably you might be more inclined to, I guess.
Correct. But in the absence of respiratory symptoms, isolated diarrhea, I would not put flu as one of my viruses on top of my differential diagnosis list.
Okay. Now here I'll be asking both of you, what is your policy on doing a flu PCR, a nasopharyngeal PCR? Do you do it before every therapy, or do you send it at the onset of every time you give oseltamivir? So Dr. Anil, you first, and then Dr. Mukesh.
No, sir. We really don't do it before starting each and every therapy on oseltamivir. Before starting anybody, we won't do it. If the child is in the IL like syndrome category B, those are moderately sick, and category C who are severely sick, yes, definitely. If they deserve an admission, usually we go ahead and do a flu swab that will guide us in therapy further. Or like what we discussed earlier, when we are using it to protect the elders in the family, we may not be doing a flu swab in the OPD setting at all.
So you would say that you would do flu swab predominantly in the indoor setting, not in the
Indoor
OPD.
setting.
But you
Yes,
may
sir.
start oseltamivir on merit. So what about you, Mukesh? When you start oseltamivir to a patient, do you do it? I mean, I'm not saying you wait for the swab report, but are you sending the swab while starting always?
No, I think office-based initiation of oseltamivir in the high-risk category is done without doing a swab. The
Okay.
hospitalized patients, you would do a swab.
Okay. So because that's when you really want to be sure where you stand. Now, my question to both of you is, you have started oseltamivir, you have sent a swab, and your swab has come negative. And this is looking at a nasopharyngeal PCR. So another one quick question before I ask this, what is the specificity and sensitivity of the nasopharyngeal PCR for the influenza virus? Dr. Anil?
Yes, sir. Post-COVID, I think the the PCR technology has taken leaps and bounds, and the sensitivity and specificity both are in the high 90s. I would say more than 95% sensitivity is there for these PCR panels.
Specificity approaches 100%, I guess.
Yes, sir. Close to 100. 95 to 100 is what the literature
So if
says.
you isolate a flu virus, the chances that the patient has flu is very, very high.
Very high, very high.
And
Only caveat here is if the sample is not collected appropriately, if it's a too
right.
anterior swab doesn't contain enough respiratory particles, so the sensitivity may drop down to even up to 60%.
Or maybe the swab is collected a little later in the illness when the particles may not be that many, but by and large, you still pick it up,
Yeah.
I guess, because
Yes,
you
sir.
even pick up the DNA and the virus may not be alive then, but you still pick up the DNA. So
Yeah.
this is the problem with the swabs. So
So
both of you, you have started oseltamivir on merits. You have sent a swab and the report, the turnaround time in your hospital is 24 hours. After 24 hours, the swab has come negative. How will you respond, Mukesh?
So, if as we discussed, the sensitivity and specificity of the test is extremely high. So, I have a swab coming negative. In the meantime, I have also worked up this child with a battery of tests. Since this child is hospitalized, he is a little more unwell. He's probably in the ICU. So, we have an alternative diagnosis. In which case, I pull out the oseltamivir. In a setting where there is no alternative diagnosis, the child is very sick. Even in that case, I would consider pulling out the drug because of the high sensitivity and specificity of the test.
Right. Do you agree, Dr. Anil? Is that your approach as well?
if we don't have any other alternative diagnosis and our clinical acumen is still saying it's a respiratory viral kind of illness, multiple mucosal involvement, probably I would still continue it for 5 days and complete the treatment.
So I think the answer depends also on the clinical setting of the child. If the child is very sick and you don't want to take a chance, and you always have the doubt whether the swab was sent properly or not, probably you may continue. But the WHO guidelines tell you that if the swab comes negative, do not continue oseltamivir. But I think the clinician has to take a decision on a case by case basis. Is that right?
Yes, sir.
Fair
Yes, sir.
enough.
That's what we do. If the
So
child is sick,
now, yeah, if the child is sick, probably I would definitely go along with Dr. Anil that I would definitely not be hesitate to stop the treatment. Now, choice of antiviral therapy, this is a table from up to date. The choice of agent according to clinical characteristics. So any of them, preferred agent is oseltamivir always, except in the age group above 5 years where oral baloxavir is an option. And later on, above 7 years, oral baloxavir and inhaled zanimivir and IV peramivir. Now, these three are theoretical possibilities in our country, not available. So for us, at all these brackets, there is no other option but to give oseltamivir. It is the best studied agent. Now, let me come to another case scenario. I have a breastfeeding mother who has a 6-week-old baby. The mother has influenza symptoms, which, according to her physician, are moderate to severe, and her physician wants to start her on oseltamivir. But the mother is worried and she calls her pediatrician. She calls you, Doc, is it safe for my baby if I take oseltamivir? I'm breastfeeding. So, Dr. Mukesh, I want your answer on this, followed by Dr. Anil.
So, firstly, the mother has moderate influenza symptoms. She qualifies for oseltamivir.
No, let's not. I mean, her physician wants to start, and that is his decision, right? So we are not
Okay,
going to dispute that. I'm saying
correct. Yeah.
if he deems it fit from the child's perspective, can you tell her to take oseltamivir?
I think it's important, extremely important from the child's perspective. A 6-week-old baby at high risk for severe influenza. We need to protect the baby also. So the oseltamivir will work on two fronts. One is obviously it will give relief to the mother, but equally importantly, it might just help us in preventing transmission of the virus from the mother to the child. And in terms of safety, since it's such a safe drug, so we are comfortable giving it to the mother despite her being breastfeeding.
So we are in that situation where it is a high risk contact, and therefore the mother actually we would prefer that she gets oseltamivir, right?
Absolutely.
So, Dr. Anil, what is the youngest age for which oseltamivir is permitted? At which
yes, sir. Considering the excellent safety profile and our growing confidence, as and when we keep on using this drug, our confidence also grows on oseltamivir, and we know that it's quite a safe drug. So the literature tells us that it is quite safe to be used in as young as 14-day-old, 2-week-old baby. This can be used. But when it comes to prophylaxis,
Yeah. So
usually the
first, I
literature
will,
says,
before that, does this baby need prophylaxis in your opinion?
no, sir, no.
No.
6-week-old baby won't require prophylaxis because the indication says that less than 3-month-old prophylaxis is usually not required.
Correct.
But when if the child is
It's
sick,
not advised in terms of the, I think may be required, but not
Exactly.
recommended.
not
Why is it not
recommended.
required? Actually, a 6-week-old baby is at higher risk than a baby who's 4 or 5 months. So I
Correct.
think in terms of indication, it is required. I think in terms of the safety profile and in terms of the safety data available,
So that's why I
maybe
mean by saying it is recommended. It is not. It may be required, but it is not recommended.
Is not
okay.
licensed.
Not
That's
licensed. Okay.
no, not licensed. Correct.
Yeah. So so Anil, you may resume what you were saying about prophylaxis.
Yes, sir. But if the baby is quite sick in the NICU, it can be used even in the preterm babies, even in the babies who are less than 14 days old. This can be used if they're quite sick. Only the prophylaxis is not recommended less than 3-month-old. But if they're sick, definitely it can be used for babies as young as 14 or even less than 14-day-old can be used.
So out of choice here, I will not give prophylaxis.
Just one question.
Yeah.
Let's be the devil's advocate and say this 6-week-old baby is a preterm ventilated baby who's been brought home and is a high risk baby, and now the mother has influenza. Would you off the label use oseltamivir?
For that, I would say that the mother is getting oseltamivir, so the chances of the baby contracting are reduced. But if the baby becomes symptomatic,
Then
even
you
a fever and a sick
correct.
child, 100%, even for a preterm baby, and I'm just coming to that, that this is the chart from Up to Date, which says that preterm below 28 weeks, you can consult with a specialist in pediatric infectious disease, but preterm 28 to 37 weeks, you can still give oseltamivir if required, 1 milligram per kilogram, and 38 to 40 weeks 1.5. So the dose varies as per the maturity, but there is no contraindication if it's a sick child. I think we'll sum it up at that, and that is the take home message. Even if you look at the first one, 0 to 3 months, it is not recommended but can be recommended in critical situations. So if the clinician deems that the child is critically sick, he would not withhold oseltamivir even in a preterm and a very low, very young infant, right?
Fair enough.
Yeah. So youngest age, there is really no issue. So now I'll come to another case, which I would request Dr. Anil to start with the answers. That I have this 11-year-old boy who has come with a history of fever, vomiting, cough, cold, and altered sensorium for 2 days. Clinically looks like a febrile encephalopathy. The X-ray chest shows haziness on the right side, and child was intubated, shifted to PICU for further management. LP was done, CSF was normal, and he was started on IV antibiotics after sending blood culture. Also IV antiviral. When I say antiviral, here I mean I am going to give him acyclovir
Recycled.
and other symptomatic treatment. Labs on admission were quite unremarkable, and the multiplex PCR was also sent, and it showed influenza AH3, but the CSF meningitis panel was negative. So in this situation, Dr. Anil, what is your approach? But before that, I'll just ask a quick question to both of you: that what is the best time to give oseltamivir in terms of the time frame of the illness?
So the best time frame will be less than 48 hours
Yeah.
from the onset of fever. That's the best time frame because as you rightly illustrated, sir, it's a neuraminidase inhibitor. It inhibits the spread of the virions and release of the virions. So
Right.
if it is given early, we can cut short the duration of the illness.
Absolutely. So here, the patient has come to you on day 3 or day 4 or day 5 with this picture. Is it kind of too late to give oseltamivir?
For someone as sick as this, it is never too late. I think it's a multisystemic illness, probably started with a respiratory thing, and now the child is comatose. Child is encephalopathic or having seizures also, and encephalitis is there.
Right.
So in such a sick child with a multisystem involvement with the background of this epidemic of flu, febrile encephalopathy and encephalitis, we always give a blanket treatment. We do cover if the child is so sick,
Especially
we
in the
go
flu season.
especially in the flu season, they do deserve a meningitic dose of an antibiotic. They are covered with the anti-flu medicines, oseltamivir. and syndromic cover is given before we start investigating them.
So, Dr. Mukesh, I'll ask you this. I'm playing the devil's advocate here, that I'm saying that CSF meningitis there was no flu. So why do you think that the nasopharyngeal PCR reflects a CNS flu in this child?
So our multiplex PCR panels, none of them include flu in its battery of tests. So
Right.
there is no way we can confirm CNS involvement in influenza except by a surrogate marker that is of influenza somewhere else in the body. And the blessed place is the nasopharynx.
Right. So I think in this situation, a nasopharynx, as Dr. Mukesh said, is a surrogate marker for a systemic flu infection. And another thing is, as we all know, that the flu virus may not be isolated because anyway we don't have a panel, but it's also an autoimmune cascade that results in CNS damage. So you don't have to show that there is a flu virus in the CSF to call it a CNS manifestation of flu. So neurologist reviewed the child, opined as viroencephalitis. Child continued to have fever spikes, and then after 1 or 2 days, the child developed features of acute kidney injury, AKI. So, Dr. Anil, in your experience, can flu virus cause AKI?
Yes, sir. If it is left untreated, or if you are a little late in initiating the treatment with the specific antiviral, they may have a progressive disease because of release of maximum number of virions. So usually it's a primary respiratory kind of a virus, sometimes in the CNS, but very rarely, yes, we do see a little bit of renal involvement and a hepatic involvement also with influenza.
Okay. So it's a multi-system disease and at some point can also cause
renal and a hepatic involvement also.
Okay.
Prakash, one quick comment. When you look at the efficacy of Oseltamivir, it says it reduces influenza symptoms definitely by a day, but maybe it also reduces lower respiratory complications, hospitalization, severe disease, and death. But when you review literature, it says maybe. So that needs to also
I think most of us have experienced that giving Oseltamivir at the right time absolutely really helps the patient's recovery, I think, and possibly may prevent complications. Especially,
of course. If it's a severe illness, obviously you would give it without looking at any kind of literature. But by and large, the evidence which is most robust is reducing duration of symptoms by 1 day.
Right. So I think we need to move ahead because we are running out of time now. So I'll just take you to the WHO algorithm, which says that suspected or confirmed flu, is it severe? And we told you what is severe, give antiviral, Oseltamivir. Is the patient at high risk of progression? And we mentioned which were the high risk of progression, or the patient exposed to a high risk patient, give antiviral. Otherwise, no antiviral. And as far as prophylaxis is concerned, we'll come to that in a while. So let me take one more case. This is a 6-year-old boy with an influenza-like illness, and on day 3 and day 4 he starts looking lethargic and sick, and you propose that you want to start Oseltamivir. But the mother is saying that, doctor, you have given him flu vaccine. Why do you want to give Oseltamivir also? So I would like both of you to know how you will react in this situation. Dr. Mukesh first.
So we all know that in a single season itself, you may have multiple influenza strains at various points affecting the same child. So a vaccine would not necessarily protect, number one. Number two, vaccine efficacy is at best 60 to 70%. So we cannot say that if the vaccine has been taken, the child will not necessarily develop influenza.
So the take-home message is that whether or not he has received received flu vaccine, if on merit he requires Oseltamivir, you will still give it. In this situation, Dr. Anil, would you do a flu swab first?
Not really, sir. If the child is sick enough to be admitted, I would do it. On a OPD basis, I wouldn't do it again.
But you may still need to start Oseltamivir in this situation.
Yes.
Even
with or without the flu swab, we need to start.
Without the flu swab, right? So that is what the guidelines say. Treatment should be initiated regardless of whether the patient has received the flu vaccine and should not be delayed awaiting the results. Also, a rapid diagnostic influenza test does not exclude influenza, but this is the rapid test, not the PCR. And a positive test does not mean, now this is another interesting thing, a positive test does not mean that it's only flu. We have had so many patients who have got a combination of flu plus RSV, flu plus COVID. So And so therefore, isolating only COVID doesn't mean that flu is not there. It really depends on the permutations and combinations of panels available in your hospital. Of course, if you do a comprehensive thing like a multiplex PCR, you'll get all this, but the cost of a multiplex PCR are usually quite high. So with that, we have been using Oseltamivir quite regularly, quite frequently in our practice. So are there any adverse reactions? I would like the panelists to tell me that what in their experience are the adverse reactions of Oseltamivir. Dr. Anil first.
It's quite well tolerated, sir. Usually, we have not come across any kind of serious adverse reaction at all. At the most, I would say they may come on day 2, day 3, tell that the child is having little bit of nausea and vomiting, and it's again settles on its own. Usually, just breaking it into a small aliquots and giving it more frequently will help. Very, very rarely, yes, we may have to give a small PPI or a anti-GR kind of measures. Very rarely, but it's very well tolerated.
So the adverse reactions are mainly gastric intolerance, GERD, and Mukesh, do you think PPI should be bundled with every prescription of Oseltamivir? As
No
some
way.
people,
As it is, we misuse PPIs, not even more so, definitely not. In fact, I have had a very good experience with safety profile with Oseltamivir. I've almost never required anything further than just a little bit of reassurance.
yeah,
Also, the cough and the
yeah.
vomiting can be a post-tussive vomiting also. So by and
Mhm.
large, I think, no, you would not give it routinely. I would not even give it if the child is symptomatic. I would just wait, reassure the parent and wait.
So I would agree with both of you that upfront, though surely we will not give. Oseltamivir adverse reactions are quite unusual in practice. But if he has a GRD-like symptom, I would definitely like to give ondansetron or PPI or antacid as the case may be. So in Japan, they have reported some neuropsychiatric effects because oseltamivir is used very, very widely over there. So neuraminidase inhibitors may cause delirium, hallucinations, etc. But on detailed analysis of that data, they have found that there is no establishment of cause and effect relationship. And some of these neuropsychiatric adverse effects may be related to the influenza virus and not the treatment. So I think this is not really such a big thing. The other question that commonly our patients ask is because the child wants to go to school, the mother wants to get him to go to school. So the child is being treated by you. Dr. Anil, what is your policy in an influenza-like illness? When do you tell them to rejoin school?
If we don't know it, like for any other viral illness, when we counsel the parent, we will say that the period of infectivity may last like for a day before and probably around 5 to 7 days after the onset of symptoms. We usually would say that till the child becomes all right, there is 24 hours of fever-free period and the cough resolves to send back to school. But here in influenza, I think the CDC tells us 24 hours of well-being, that is afebrile period without having paracetamol.
That is
The
more
child
related
is
to the practicality of the child. That even when you tell your parents keep the child home for 5 to 7 days, there is very, very few who will really do that. And which is why there is such a lot of transmission of viruses in the schools. But as you rightly said, the CDC says 24 hours without an antipyretic. Mukesh, the mother tells you,
One
doctor, you have
question,
given oseltamivir, can I send him to school tomorrow?
Prakash, no. I was wondering if a child has varicella and he comes to you, when do you send him back to school?
Yeah, for varicella, it's a different story. The scabs have to be, it has
Yeah,
to
but
be,
basically, we're looking at how long does virus shed. And
yes.
we know that the influenza virus sheds for 5 days. So
But yet,
I don't understand why CDC should say you can go back in 1 day in this and 5 days in varicella.
that is true, but we are sharing the guidelines because I think they are more real world guidelines.
Okay.
Because once the child has got 2 days, he's fine, and he starts making start jumping around at home, and the parents are losing their working days. So obviously nobody waits. So I
But he's
think
going to give it, he's going to give it to his friends then, no?
that is exactly what happens, which is why we are so busy in the monsoons. So this is about, so the CDC says 24 hours. I think we can stick by this even on a legal basis. Now but the mother says, doctor, I've given oseltamivir. Should I even wait for 2 days? What do you think?
Yeah, so I think Oseltamivir, since it reduces the duration of symptoms by 1 day, if you're going to send the child without Oseltamivir within 24 hours after no fever, then you send this guy much earlier back to school,
I
Prakash.
don't think it's so. So basically,
Yes,
this
same recommend.
recommendation applies whether or not the child received
Yes,
oseltamivir. So
yes,
even if he has received oseltamivir, you have to wait till 24 hours after the
right.
fever resolved without antibiotics.
Fair
Okay.
enough.
Yeah. So now, many times in a situation when the child has fever and respiratory symptoms, we may be tempted to start antibiotics, antimicrobial. Dr. Anil, does using oseltamivir rationally help in antimicrobial stewardship? What do you think?
Yes, sir. Even doing a swab or using oseltamivir will definitely help us, because we know that child gets better. Once we start oseltamivir in 48 hours, things are getting better. That
Right.
kind of, we kind of hold back on the antibiotics, or even having a positive test on the flu swab kind
Yes.
of tells us there is nothing else happening. So that I think we are more confident when we are holding
So
back
there
the
is
antibiotic.
interesting data from the UK when they started giving flu swabs and giving oseltamivir, the antibiotic prescriptions substantially came down as they used to be in the flu season because people were indiscriminately giving it over there. So this does diagnosis does help in AMS. And for want of time, I will not discuss this case with my panelists, but quickly tell you this about this 10-year-old boy who came with fever with rigors and headache, and the tonsils appeared a little large, and there were some white spots on the tonsils. So my resident doctor who was with me in the OPD said, "Sir, this is follicular tonsillitis," but it wasn't. There was no lymphadenopathy, no halitosis. These were actually tonsillar crypts. So when to start or not? So here we did the flu swab. The flu swab showed flu, and here, in spite of the so-called follicular tonsillitis-like picture, we were able to avoid antibiotics because it responded to influenza. So definitely, AMS is achieved that way. But on the other hand, sometimes I feel that are we overdoing oseltamivir? A one-line answer from both of you. Do you think that we are sometimes overusing oseltamivir?
Yes and no, sir.
Okay.
In some situations, yes, we are using it indiscriminately when it comes to prophylaxis. But in treatment, many a times we are kind of hesitating and holding back also, even in treatment. So my answer is both yes and no.
Mukesh?
Yeah, I think in epidemics, I still think it is underused.
So epidemics it is underused, but so I think we should more worry about using it at the right time. But I think sometimes people who are not, especially non-allopathic doctors who are not so well informed, they may tend to use it without proper indication. So I think, as you said, I completely agree with Anil. It's a yes/no story. Let's take one more case of an 11-year-old girl with fever since 2 days, high-grade fever, not with chills and rigors, and she was dull in the interfebrile period. She came to us with tachypnea, difficulty in breathing for 2 days, and associated with post-tussive vomiting. And the child had severe bronchospasm. Now, in this situation, the interesting part is that last month she was admitted to another hospital and they found influenza A, and they gave oseltamivir for 5 days. The child was better in between. My question to you is that in this situation, in the flu season, she has received oseltamivir last month. Will you repeat the same?
Yes,
Mukesh?
sir.
Okay, anyone? Yeah.
Yes, sir. Yes, sir. Because we know about the antigenic shift and the drift phenomena which happens, where the virus itself may kind of change the antigenic structure, or we may suddenly have a new strain itself. So
Not to
it could
mention
be a
that not to mention that influenza can be A or B. So
A
how
or
do
B
we know
also.
that
It
this
can be
was not
different
B, right?
strain altogether.
So this child was put on HFNC and then given injection ceftriaxone, Dexa, again started oseltamivir, azithromycin nebulization. So this was done, and the report showed influenza B plus RSV. So the take-home message here is that even if you are given oseltamivir last month, there are so many flu viruses, there are different strains. So it does not mean that on merit you will withhold oseltamivir in a child who requires it based on the clinical condition. This was B plus RSV, and she responded to a second dose of oseltamivir. Thereafter, this child was given a flu vaccine, which should have been given. This was the X-ray of the child. So, now during oseltamivir therapy, sometimes we do add an antibiotic. So, Dr. Mukesh, what are your indications for adding an antibiotic during the therapy with oseltamivir?
So one concern is if it's a serious child in the ICU where the margin for error is very small, that child you would initiate empiric antibiotics pending investigations that come back. So that group you would. We are really concerned also, even if the primary diagnosis is influenza, we know that these patients are more prone to a rapidly progressing and fatal pneumonia due to superadded infection like strep pneumonia, strep pyogenes, staph aureus. So if you have
Right.
a patient, number one, who's very serious, number two, who's not improving despite 48 hours of oseltamivir, or a patient who has improved and then worsened, or the fever recurs in a otherwise improving patient, or there is a localizing sign somewhere,
Yes.
then you would use antibiotics
So if there is a
upfront,
focal
or
infection, there is a lobar pneumonia, or there is a sign of bacterial co-infection like persistent fever, as you said, neutrophilia, high CRP, probably you may need to think of secondary infection and add. And which is the commonest secondary pathogen in flu?
so as I mentioned,
Strep
it's
pneumo.
Strep
strep
pneumonia.
pneumonia, strep pyogenes, staph aureus, all three.
Yeah, we have a very little time left, so I'll quickly ask you. This will be a one-liner for both of you. That when will you give oseltamivir prophylaxis to a child? Will you give it that the child is admitted with you? The parents are there. Will you give them oseltamivir prophylaxis, Dr. Mukesh?
If parents are at high risk,
Only if they are at high risk. Okay.
more
What
than
about the
65 or
grandparents of the
immunocompromised,
now the child is
parents, same story.
was admitted for 2 days. He's fine now. After on the third day, you're discharging him, but he's going back to a family with grandparents there. Will you give grandparents prophylaxis, Dr. Anil?
Yes, sir. If they're aged like 65 and above, yes, we would go ahead and give
So
them
here
the
the
prophylaxis.
WHO says 85, but of course I think it has to be on a case-to-case basis, especially those who have comorbidities 100%. What about the younger sibling of the influenza patient?
Yes, sir. Less than 2-year-old is definitely indicated as he or she comes in a high risk zone.
Correct. So between 3 months and 2 years, I guess.
Correct.
You're right.
Yeah. So post-exposure is intended only for individuals if there is a high risk of hospitalization if they contracted influenza, and should not be arbitrarily expanded, and post-exposure of is not a replacement for flu vaccine. Now, is there any role of oseltamivir beyond flu? Now, I had a child admitted yesterday, 2 days back, with a croup, laryngotracheobronchitis, high-grade fever, lethargic child, and the swab showed H para-influenza, showed the para-influenza virus. So, if I get para-influenza virus, do I give oseltamivir, Mukesh?
No, you don't.
What about you, Anil?
It doesn't
No,
work.
sir. No, sir. Doesn't work.
So let's understand that merely because there is influenza in the name, it does not is not going to respond to oseltamivir. There is no role of oseltamivir other than an influenza virus infection. So after all these things, is there any contraindication at all to oseltamivir? Quickly, Dr. Mukesh.
No, there isn't. It's a safe drug, extremely good profile. Unless there is hypersensitivity to one dose, no contraindications.
What about you, Dr. Anil?
Very, very rarely it is described in literature like hereditary fructose intolerance and all, which we rarely see. So
Okay.
it's not really, there are no specific contraindications.
So there may be some relative contraindication like child having active bleeding, malabsorption, bowel obstruction. But since in our country peramivir is not available, we will still have to find a way in this situation to give oseltamivir where it is indicated. Is pregnancy a contraindication to oseltamivir?
No, sir.
No.
It's safe to use in pregnancy.
Yeah, so there are a lot of studies where they showed that oseltamivir in pregnancy does not have fetal or neonatal malformations, and it is quite safe. Not only that, pregnancy is a high risk state, so they may be more likely to require. So
Absolutely.
does oseltamivir have any? Now this is a child with a kidney renal insufficiency, chronic renal failure, and he develops a flu-like syndrome. So here upfront, I have to give oseltamivir, Dr. Anil. Does the dose need to be altered in any way?
Yes, sir. Only the dosing precautions will have to be taken according to the creatinine clearance. Otherwise, it's quite a safe drug. In the appropriate dosages, when it is used, it's a safe drug.
So renal insufficiency definitely an indication for altering the dose in terms of creatinine clearance. Mukesh, is there any interaction between flu vaccine and oseltamivir?
So you would avoid giving it while child is on oseltamivir, and as you rightly said that it's a killed vaccine. So live influenza vaccine, yes, you need to be careful. With the killed vaccine, which is the one which is the only vaccine that is available in India, we are good with using the vaccine as long as there is a 2-week interval before or 48 hours after the
No,
drug
actually,
is stopped.
that is true for the inactivated influenza vaccine, that you can't give it when within 48 hours of stop, before 48 hours are over after stopping the drug, as well as 2 weeks of. I mean, suppose you had to give if you had given the inactivated vaccine and you give oseltamivir for whatever reason within 2 weeks,
Correct.
that is not going to, that vaccine won't seroconvert. Also, if you're giving oseltamivir and you don't wait for 48 hours after stopping, you can't give the live flu vaccine. But as far as the inactivated vaccine, there is no problem. Sometimes they say, yeah, they say that even during therapy, giving inactivated vaccine is not a problem. The problem comes with the live vaccine. So
But by and large, you would not give the vaccine during treatment, no?
No, I agree with you. You
We
will
won't, sir.
not give during treatment, but if you are pushed to the wall for some reason, or it is just maybe just a theoretical question that oseltamivir does not interfere with seroconversion of the inactivated vaccine. It interferes with the live because it may destroy the live vaccine and therefore prevent the
Correct.
seroconversion. Now, so I think we are coming to the end of our entire canvas of oseltamivir, and I thank my panelists for giving such pertinent and perfect, short, crisp answers. I'll just sum up before I stop sharing that oseltamivir is currently the only anti-influenza drug available. It is very useful in treatment and prophylaxis. You must know the indications for both treatment and prophylaxis very well. Use it timely and wisely, and let's not use it indiscriminately. With this, I thank my panelists and I'll stop sharing the screen.
Thanks, sir. Thank you so much. Thanks for some nice discussion, Thanks
Thank
so
you.
much.
Thank you.
Yes, thanks
Thank
all
you,
the
sir.
panelists, and thanks all the doctors who took time and attended this. Thanks, Nagadevi. And we can log off, sir, and join again after 10 minutes
Okay.
in a
Thank you,
different
sir.
speaker.
Thank you.
Thank